First of all, I want to thank you for the invitation. The way that I was introduced, I do have a lot of titles, and I really don't care about those titles because what I really care is about helping my patients and enjoy survivors. And I really love to do that because having the survivors means that what I'm doing, what little thing that I'm doing in my work every day is helping in some way for the patients to be alive and survive. And paying attention what Chantis was saying, the first thing that came to my mind is thanks for research, because with research we have been able to find absolutely amazing target drugs that today can keep patients like Chantis alive, doing well, and looking wonderful. So that's my passion and that's what I do. She forgot to mention when she was talking about her hair that people ask her about where do you do it? She forgot to mention that she has to say Forero's hair, right? I was part of that. So let me tell you a little bit before we will start talking, and I would love to have questions, and for all of you who have been in the New Light meetings, you know that I love questions because I'm here not to teach you, but to help you. And if you have questions, then we can have a nice conversation, and this will be helpful for you, and you can take those messages home. But before I will start with answering the questions, let me tell you a little bit about breast cancer. One important question that Chantis mentioned. Today is not only important to know that you have breast cancer, it's very important to know what type of breast cancer is the one that you got. Because nowadays it's not the same thing every breast cancer. 40 years ago, 30 years ago, everybody that got breast cancer was treated exactly in the same way. And that's absolutely completely wrong today, because we have found through research that there are many, many different types of breast cancer. And they are different because they have a different prognosis and a different treatment. So not everybody is treated in the same way. So today, when they tell you you have breast cancer, when you receive your call, the next question has to be, okay, what type of breast cancer do I have? So based on that, I can make my decision about how I'm going to be treated and what do I want to do with my life. And remember, and for you that have gone through this period, but for the new people that will be diagnosed with breast cancer, there is no rush. Never is a rush. Never is that you have to go surgery yesterday. Never is that you have to schedule surgery tomorrow at 7:30 because you are going to die, because that's absolutely false. So the next question is not, okay, when are you going to operate me? But the next question is, what type of breast cancer do I have? And based on that, I will go and document myself, read about it, talk with my doctor, and then pick my treatment. So let me tell you a little bit about the types, because based on those types, then the different prognosis and treatments. So all of this is based on what we call markers, and that's what Chantis was talking to you when she was talking about her cancer. There are three important markers in the tumor cells that you need to know to understand your breast cancer. One is what we call the hormone receptors. Those are two. Estrogen, that's the main hormone in women, and progesterone, that's the second hormone. Why are those important? Because some of the cancers, about 50%, half of all the breast cancer that we diagnose today in the world, are hormone dependent. That's what we call estrogen or progesterone receptor positive. What it means? That means that the hormones, estrogen and progesterone, are feeding those tumor cells. So if you keep in mind that those cells that are hormone positive, that are alive because they are dependent on eating estrogen, so it's very easy to understand that the most important treatment for patients that have estrogen and progesterone receptor positive breast cancer is not chemotherapy, is blockers of the hormones. get rid of the food that is feeding my cancer. So if I get rid of the food that feeds my cancer, those cancer cells will die. Those are what we call the estrogen and the progesterone receptors. And the third one is what Shantiz was talking about, is what we call HER2-neu. HER2 is a gene that is in the tumor cells. It's not a gene in your normal cells. It's not what predisposes you to have breast cancer. It's a gene that the tumor cells develop. And about 25% of all the breast cancers in the world have that little gene. And what it happens is that that little gene is like the engine of the tumor. It makes the tumor aggressive. It makes the tumor unhappy. It makes the tumor to spread very early on. And for years that was a problem because we didn't know what to do. We didn't know anything how to handle it. Certainly chemotherapy was not the most important therapy, but everything changed when we discovered a medication that was what we call target, because this medication called Herceptin that you heard Shantiz talking about, and some of you that I know have received it, that medication, what it does, it's find those tumor cells that have that little gene inside, find them and kill them. So when that medication was found, then the HER2-neu positive breast cancer, which it used to be a bad cancer, a very aggressive cancer, has become one of the cancers that, number one, we can cure. Number two, if we cannot cure, we can control for a long, long time. So I expect Shantiz to be here with us for a long, long time. So today, going back to the question, you need to understand that. So the third question is, okay, what is my type? But you tell me what it is, because my type depends on those three little things. In the future will be one more, and we'll talk about a little bit about that one. So based on those three receptors, there are 4 types of breast cancer that are recognized today. Number one are what we call luminals. Luminals, whatever. We physicians use strange word. Why they call luminals? Luminals. Luminals are hormone-driven cancers. Those are the cancers that depends on the hormones. And there are 2 types of luminals. What we call luminal A and one that we call luminal B. Luminal A is a completely hormone-dependent cancer. So when you take your report and you read your report in the pathology, and they will say estrogen receptor positive, then the next, what it be next in the report will be is 3+ in 95% of the cells. That means how many of my cells are estrogen receptor positive? Because normally in a luminal A, everybody, all the cells are positive, but in the luminal Bs are not. And you can have a tumor that is 50%. So half of the cells have it, half of the cells don't have it. So based on that, we divide the luminal. So luminal A is the one that is completely hormone dependent. 100% of the cells depend on hormones. And it's important because that's the one that we usually see in older patients. That's usually a non-very aggressive cancer. And that's a cancer that we control really well blocking the hormones. Because if they all depend on hormones, we block the hormones, we get rid of them. That's what we call luminal A. Luminal B, in the other hand, is the same dependent in hormones cancer, but not all the cells are hormone dependent. So half and half, or 1/3, or 2/3. So there are some cells that are not hormone dependent. Well, if you keep that in mind, so the treatment is block the hormones, and that will control half of my cancer. But what about the other half? Well, the other half, you control it with the other treatments that we have, which the majority of the time is chemotherapy. So if you are luminal B, then at some point you need to think about both treatments, chemotherapy and hormonal therapy, because you need to attack every single cell. And that's what we call luminal A and luminal B. So you have to ask your doctor, what is my type, luminal A or luminal B? Because depending on that, my treatment will be different. The third one is what we call HER2-neu positive, and that's what Shantiz was talking, is the one that has the little gene. And it's important to know that, because if you have that little gene, remember what I told you, there is a magnificent drug called Herceptin that attacks that gene. So for patients with the HER2 positive cancer, the main treatment has to be that medication or the subsequent medication that we have developed, which that medication works really well in those patients, but doesn't work in the other ones. So do you need to know your type? Absolutely, because you depend on that. So the third one is the HER2, and the treatment is based on that protein. And the fourth one, which is the one that I have been working for many, many years, and that's my passion, is what we call triple negative. Triple negative means those cells are not estrogen or progesterone dependent, so blockers of the hormones don't work, and they don't have the HER2. So the Herceptin or the new Herceptins that we have been developed don't work. So the only thing that we have for those patients so far is chemotherapy. So it's absolutely a different treatment of the other three. So now you can tell me that when your doctor talks to you, you need to know what it is. Because if you don't know what type of breast cancer, you don't know what to do. And certainly every treatment is absolutely different according to the type of cancer that you have. In the very near future, and this is something that when I talk with my patients in the new life for the triple negative breast cancer that we talk a lot, is there is one more marker that is coming very soon in the clinic, and it will be very important, is what we call the androgen receptor. Androgen is the male hormone. It's what we male have. We have androgens. Right? Testosterone is my hormone. Like you have estrogen, I have testosterone. So in men, prostate cancer depends on androgens. So my androgen can feed prostate cancer cells. So the main treatment today for a patient with prostate cancer, as in the females with hormone positive, in males is block the androgen. So if I take a pill, very similar to the pills that we use in breast cancer, I block my prostate cancer and I will do well. That's what we do in prostate cancer. Well, through research, we now have found that in the triple negative group of patients, and now more recent data suggests that also in the estrogen receptor positive, that some of those tumor cells in the females are androgen receptor positive. So that means in some way, androgen, and believe it or not, you females have a little bit of androgens. And I male, I have a little bit of estrogen. But sometimes, the little bit of androgen that you can have can stimulate the growth of those tumor cells that have the androgen receptor. So, in the near future, there is a pressure around the world, and if you have been dealing with triple negative breast cancer that is a spread, that's one of the first tests that we're trying to do, get the androgen receptor analyzed, because what we have done in those patients is use the medication that we use in prostate cancer, but we use it in females, because if that will block the androgen receptor, then if that cell depends on androgens or testosterone, the cell will not have anything to be fed and the cell will die. I'm telling you about that one because that's coming into the clinic. There are many other ones that are coming that are still in evaluation, but they are coming into the clinic. So I want to keep you with that in mind. Type of breast cancer, and you need to know your type before you can decide what you want to do. Going back to my question, and I'm sorry it took me forever to answer. Going back to my question, research is one of the most important avenues that we have in order to have survivors. Without research, we will not have all of you here. You know, 100 years ago, when the only thing that we understood about breast cancer was to get rid of both breasts in a horrendous, horrible way, we lost everybody. We lost everybody. We really didn't save a lot of people. But now, through research, when we have discovered all these new things that I told you about, the different types of breast cancer, the different drugs that have been discovered, evaluated in research, approved by the FDA, and that now are available for each type of breast cancer. The wonderful new drugs that are coming down the pipes. There are tons of amazing medications that are being evaluated at this time in clinical research. Those are the ones that have moved the field ahead, and that's what it has allowed us to have you surviving and enjoying having you around us. So without research, we will not survive and we will lose it. So we need to keep doing research, and that's the reason that is my passion to stay at UAB and work at UAB. We can spend hours and hours talking about the different developments in each type of cancer. Each type of cancer that I mentioned has a tremendous amount of new developments that we can spend hours and hours. But I don't want to concentrate my time on that. But if you ask questions specifically about things, I'm more than happy to help you. Last thing, and I always say that because my passion is triple negative. When you Google triple negative, and for those that are triple negative, and especially young survivors, breast cancer in young patients, many times is triple negative breast cancer. When you go on internet and you type triple negative breast cancer, you Google in Google University, what you will find is horrendous. You know, every time that we diagnose someone with breast cancer that receives the call and said, you have breast cancer, and then the next word is, do I have triple negative breast cancer? And it's yes. It's devastating because you really go on internet and you find horrible things, horrible, terrible, dramatic things. You will be scared. Nobody survives. Everybody dies. Well, that's a lie. Big, huge, big lie. There is a huge, big percent of patients that survive and do well with triple negative breast cancer and are all chemotherapy well, and I bet you some of you have been receiving chemotherapy and alive and surviving because of that. There is a small group of patients that chemotherapy don't work, and that's the group of patients that we're working every day trying to find something better. And that small group of patients is the one that motivates us. But not everybody. So when you have a friend that has been diagnosed with triple negative breast cancer, help them. Don't tell them that they are going to die because it's not true. There's a better chance that she will survive than she will die. All right, now, I'm open, whatever you want to ask.
How long has the research community known about the medicine treatment for HER2 positive?
How long?
I was diagnosed 3 years ago in October 2013, and I was rushed into surgery. It was DCIS stage 0, and I mean, I'm a reasonably intelligent person, and I can walk this out, but hindsight's 2020, I don't feel like I got the kind of education I needed, or tell me the terms. If I have a question, I'll ask you, or I'll look it up. You know, but mine was HER2 positive, and I apparently had qualified for some kind of a research, but they weren't able to get those results back until, I think, 13 days before surgery, and they needed to have me on some medicine 15 days prior to surgery. And so, I mean, what's done is done, but how long has the research community known that this medicine could treat HER2 positive? And then I have a second question to follow up.
You had two important questions, and I think I talk about the first one, which is the most important, and I tell my patients all the time, you know, in clinic that happens every day. There is no rush to start any treatment immediately after you receive the call that you have breast cancer. That's a big mistake. That business of starting chemo yesterday, going surgery tomorrow morning at 7:30 because you are going to die is a lie. The most important part of making decisions and in order to be a survival is to take your time. You have to document yourself. You have to learn about the disease. You have to talk with your physician, and you have to make the most appealing decision for your treatment before you will start your treatment. Because it's clear in cancer, and not only in breast, in every cancer, your first treatment is your first opportunity to be cured. So if you miss that boat, you can miss the boat of being survivor. So never be in a rush. Never be in a rush. Take the information, analyze it, look for resources. You have tons of resources today. Breast cancer has tons of options. So never rush yourself, document yourself. Number one. Number two, Herceptin and HER2. Herceptin entered in clinical trials about 30 years ago. And it went through huge big clinical trials through United States and Europe. And after trial in the United States with 5,000 patients and in Europe with 5,000 patients, when they analyzed the data, that's when we found that Herceptin plus chemo cures patients. And the prognosis of being bad disappeared when we found the drug. But at the same time that we evaluated and discovered and approved Herceptin, immediately after that, everybody around the world that works in academics start finding new drugs. And that's what the people call the new Herceptins, which in reality is discover new drugs that can target the HER2 gene. So Herceptin, which is what Chantis received to begin with, is one way to attack and destroy the gene. But there are at least another 4 drugs that have been approved after Herceptin that target the same gene and destroy the cells as good as Herceptin. The new research is moving all those new drugs, instead of being used in metastatic disease, to move it upfront in early disease and see if we can improve the cures, and we'll be curing 100% of the patients, or if we don't need to use chemotherapy anymore. I'm talking about HER2 cancer. So I always tell my patients the story. HER2 positive breast cancer was a bad disease, and it was hard to talk with the patient because we knew the patient was not going to do well until Herceptin appeared. When Herceptin was discovered, the physicians or the scientists, what we did was we were using chemo, even though it was not working, and we add Herceptin, right? That was the logical thing to do. And we improved the prognosis of the patients. So now that we know that Herceptin is the one that changed the life of the patients, the question is, can we get rid of the chemo? Do we have to use only the Herceptin and the new drugs that attack the gene, so it will be a non-chemotherapy regimen? And that's where the field in research for HER2 is moving. Target drugs.
So is surgery necessary?
Excellent question. Yes, and in the future, maybe not. Stop and think, find information, and make a decision. Let me tell you a little bit about the part of the surgery, because this is another important part for patients when they are diagnosed with breast cancer. The first thing that comes to the mind of a patient that has breast cancer is get rid of the breast. It's the usual, it's the normal, right? If I have breast cancer, get rid of my breast. That will cure me, right? Or get rid of both breasts. That will cure me double. So if you go back to the history of breast cancer therapy, if you see how many patients did we cure with surgery, I will tell you very little. Because it was so frustrating for the surgeons that they did these horrible operations 50 years ago, and then 6 months later, 12 months later, 24 months later, the patients came back with metastatic disease. So it was very frustrating. When the people start thinking about what happened, the people start thinking, well, the problem is that the little tumor cells escape the tumor before the surgery, not while on surgery, before the surgery, and those little cells go outside. So if I go and concentrate in the breast and do only breast surgery and forget about the rest, I will fail. I will fail. That little cell that may escape will stay there and will grow. When we understood that and we found drugs, that's the reason that we drugs after surgery. We use chemotherapy, blockers of the hormones, target therapy, whatever you want to do. Those drugs are designed to go there and kill that little cell wherever it is located. When we understood that principle and we treated the patient, that's when we start seeing survivors. But when we were doing surgery, forget about it. So it's important when your friends go through and you go there fixated, surgery, both tomorrow, 7:30. You have to stop and say, listen, you need to think about it. Because the treatment of breast cancer is not your breast, it's your body. It's your body. And when we understood that, that's when we went from these bilateral, horrible, terrible surgeries to what we do today, which is lumpectomies. Today, we have shown that if patient is treated well with drugs, patients can go with lumpectomy. They don't have to get rid of the breast. The majority of the women don't have to. And in the future, I promise you, I assure you, that in the future, will be a group of patients that will never go for surgery for breast cancer. There is a very nice trial that is promoted by 2 investigators at UAB. Not that I want to be advertising UAB, but it is true. Heidi Humphrey in radiology, some of you know her, and Jennifer De Los Santos, a radiation oncologist. They have been working so hard in a big clinical trial that it will run nationwide, in which patients with breast cancer that receive treatment before surgery, in which at the time of the surgery, the images show nothing. Half of them will go for surgery or radiation, and half of them will go for radiation alone. So that will be the first trial in the whole world, and it will be run in the United States, in which we are going to ask the question, do we even have to have lumpectomy in early breast cancer?
So Dr. Forero over here, Denise had her.
Hi.
Hi.
First, wanted to say, yeah, you're totally right on getting education beforehand. When I was first diagnosed, my surgeon scared the ever-living bejesus out of me because it was on a Monday. I went in on Tuesday and cleared my desk, told everybody at work, I'm going to be out for the next 6 weeks, because she told me that she was going to clear her calendar because my breast cancer was so aggressive and so horrible and so rare that she had to get it out immediately. And Wednesday or Thursday, I was going to have surgery. Scared, I cannot tell you how terrified I was, but I took a step back, talked to people around town, got a different surgeon, and actually when I went to see the second surgeon, she gave me worse news, but I felt so much better. I was almost crying with relief that it was explained to me and what I had and what this meant and what that meant. And it just did so, it really set my journey off on the right footing, in the right pair of snazzy shoes to get this done. So I just would say, please, if you have any questions, keep going to another person, keep trying to get another person, because this is someone, I look at my journey as it's an RV, and various people are on the RV with me. Right now, my oncologist is driving, but soon my surgeon's gonna be taking over and she's gonna be driving, and then it's gonna be my radiologist that's driving. But find good people to be on your journey. But my question is, yesterday was my last treatment for chemotherapy. So yay. I cannot tell you how excited I am. I really want to get my body back, and the smaller me too. But I am so afraid that it's going to come back in some other way, because my thoughts are my body knows how to produce breast cancer. My body knows how to produce cancer. And I had a large fibroid in my breast that I always knew was there, but it suddenly went rogue. And in 7 months between my mammogram to when I was diagnosed, it became cancerous along with several other cancers, tumors. So I'm afraid that if my body already knows how to produce cancer, it might know how to produce somewhere else. What can be done to yearly PET scans? What? I mean, breast cancer is, to me, one of the easiest ones to diagnose because you can feel it yourself, but you can't feel liver cancer. You can't feel, pancreatic cancer. You can't feel those. So how can I be more aware of what's going on in my body, and what do I need to look for to see if the cancer decides to spring up somewhere else?
Good question, very good question. So let me answer a little bit with the history, because all of this is history, the way that we learn. Yes, once you become a survivor, and you become a survivor, the next day you were diagnosed with breast cancer, no doubt about it. You don't have to wait until you finish. You are a survivor. Once you are a survivor, the first thing that will come to your mind every time, every minute, for the first weeks or years, is, oh my God, I have nail pain, the cancer came in my finger. I promise you, that happens. Did it? So that's the fear that you are going to experience. That's the fear that survivors feel all the time. So based on that fear, the next step is exactly what you said. God, go ahead and scan me, do PETs, CATs, MRIs, bone scans, every 3 months, or every 2 months, or every month. Do it weekly. And that's the way that you compensate, right? If you are scared, so you do it in that way. Well, there were two pieces of information that have told us what to do about that. Number one, there was a big, nice study that was done many years ago in which we took two groups of patients. One group of patients, we did exactly what I just said. We went and had scans, PET scans, MRI, everything every 3 months or every 6 months for a long, long time. And in the second hand, we did a very rational follow-up, which it was seeing the patients every 6 months, check the blood for your liver enzymes and your bone enzymes, because those are the two organs that the breast cancer usually go, do a chest x-ray every year, and do your mammogram if you kept your breast, do your mammograms according to what the radiologist will tell you, usually every 6 months for the first 3 years, after that every year if everything looks good. And the study clearly showed that no matter what you do, you are going to live exactly the same amount of time. So doing all these MRIs, PET scans, CAT scans will not allow you to live longer. Number one. Hard to keep in mind, but it is what it is. Now, the second piece of information is the one that it will really change your mind. And it was a very nice study that was also being published in the big medical journals and a lot of publicity, in which a group of investigators clearly showed that the more you lie in those tables and you allow your body to be irradiated, PET scan irradiate, CAT scans irradiate, MRIs, not a lot, but in some ways in the machine, etc., that study shows that the more you lie in those tables, the higher the chance of catching acute leukemias and something that is horrible that is called myelodysplastic syndromes. So, in one hand, doing all those scans will not allow you to live longer. In the other hand, that can put you in trouble, and nobody survives acute leukemias after breast cancer treatment. That's the reason that we don't do it. So my suggestion is you need to see your doctor every 6 months, have the simple follow-up with your blood test, your chest x-ray, your mammogram every 6 months, and have your doctor follow you. If you have any problems, if you have any symptoms, if you have anything that is different, call your doctor. I receive calls all the time. You know, my cancer came in the nail. I can see it. Call it. That's okay. That's not a bad thing. With the passage of the time, you will learn what is real and what is not. But that's the best thing that you can do, number one. Number two, survivors. This is a very important part. When you go on the internet, remember, we Google everything, right? And then you will find, take vitamin D. No, don't take vitamin D. Take calcium. No, don't take calcium. Eat spinach every day. Don't take sugars. That's horrible. Forget about the chicken with hormones. Eat meat that is organic. That you will become at some point absolutely crazy. What do I have to do? Do this, do that, and they call you and you see it in television. Your friends give you this and give you that. Reality. None of those things are real. Absolutely. You have to have a normal life. Normal life. That's what you need to do. The only two things that have been associated with prognosis on breast cancer is number one that majority of us don't like, which is exercise. It is what it is. It is what it is. I don't like it. It's not my deal. But the good thing about it is that the studies that have been done with exercise is not that you have to run 5 miles every day so you will be healthy. That's not the way. If you do whatever you like, pick whatever you like, whatever, what you really will enjoy doing, and do it 3 or 4 times a week, and do it for 15, 20 minutes. It's all you need. If you want to walk outside, the weather is wonderful, walk for 25 minutes. If you like to swim, go and swim a little bit. That little amount of exercise will help you with your prognosis, number one. Number two, eat healthy. Don't go extremes. Soy products, no soy products, sugar, no. Eat healthy. Eat your protein, your vegetables, your fruits. Try to avoid the bad stuff, right? The sugars, the starches, because that will help you with your weight. And those are the 2 most important things that you need to do. If you eat healthy, and we all try to do the best, and you exercise, that's the best thing you can do.
I want to know about chemo. Now, from what I have done my own personal research and looked at Texateer. I understand about the hair growth, but for Texateer, for me, Texateer did the worst to my body in my chemo out of all my chemos. I have neuropathy, and I have, that's extremely bad, and I have lymphedema. And what I noticed is when I went to a conference in Tampa called the Women of Color, I personally talked to each woman, and they were affected by Texateer. So my question to you is, have you guys did any research to see how Texateer affects certain ethnic groups compared to others? Or have you done any research to see after the Texateer is used, how many people are affected, you know, in a bad way on the side effects of that? Because the chemo for me wasn't the problem, it's the side effects afterwards is what has gotten me. But that was my question to you. And to the ladies, please get involved. It's only a phone call.
All right, so let me just tell you a little bit about the little things that you talk about, the important things that you talk about. Chemotherapy still is part of what we do. Don't doubt it. But if you read and if you learn and if you pay attention to the types of breast cancer I told you to begin with, you can sense that chemotherapy is being used less and less and less. And the reason that we use less and less and less chemotherapy is because, remember, chemotherapy was used to treat everybody, but not everybody can be treated in the same way. And number two, remember that now we are moving into target therapy. In every cancer, in every type of breast cancer, we're moving target therapy. That means we target the tumor cells with drugs. And that's a big difference with chemotherapy, because chemotherapy is dumb. And it's the reality, chemotherapy is dumb. Chemotherapy goes inside and kills the bad cells. That's what we know, and that's what we want, and that's, don't get me wrong, we have cured cancers with chemotherapy, it's the reality. But unfortunately, chemotherapy kills and hits many normal cells in your body. And that's when we develop toxicity. And each medication, each chemotherapy drug that we use has a different sets of toxicity. So it's not that only one produces, or as the patient said, are you going to give me the worst chemotherapy? It's not the worst. It's that every medication is different and affects in a different way. And unfortunately, every patient is different. So the majority of the patients will not have many problems, but there is always a minority of the patients that will develop problems with each of the different drugs. So you talk about Taxotere. Taxotere is a class of drugs that we call taxanes. There are three different ones, Taxol, Taxotere, and Abraxane, are the same class of drugs. And the main problem with those drugs is exactly what you just described, which is the neuropathy. Those medications affect the nerves, and when you affect the nerves, you develop the neuropathy. And unfortunately, neuropathy is a very sensitive problem, because you start with the numbness, the tingling, and sometimes that extends, and the more you receive, the more you will be. So yes, there is a percent of patients, and we know every drug, we know what it happens with every drug, and we try to minimize as much as we can while the patients are going to treatment. There are many things that we do while on treatment, but there is always a percent of patients that as a secondary effect later on will have that secondary effect. Some patients will recover with the pass of the time, some patients not. It's a matter of trying to live with that. In the future, my goal as a scientist and knowing what we are going is that chemotherapy will be the past. And as the same way that I said that in 15 years surgery will not be used, I hope, it's not me, I think that chemotherapy will disappear from the treatment of cancer at all, including breast cancer, if we keep the trajectory of research finding the new drugs.